Okay.
Hello, everyone. My name is Chris. I'm a second-year med student down in Scranton, PA, Geisinger Commonwealth School of Medicine.
Nice. How about for others? MS1 from UPenn.
I'm a MS4 from St. George's, currently in Pittsburgh right now on a little bit of a break.
Nice. Anyone else willing to share? If not, we can get started, I guess. So you're recording now, Evan? All right. Oh, hi, Mira. Thank you. MS1. What's GW?
I think it's George Washington University
Okay.
in Washington, D.C.
Cool. All right. So I will share screen that. All right. Are you guys able to see that okay there? You can hear
Yes,
me
that
okay?
looks great.
Okay, perfect. All right, well, thank you for having me to talk about dialectical behavioral therapy, or DBT. Like Evan said, I'm a psychiatrist at the Center for Addiction and Mental Health in Toronto, and I work at a BPD clinic doing mostly DBT. So I had a few objectives for the talk, but if people have other interests, I'm happy to kind of shift things if that's helpful. So I was hoping kind of by the end of the presentation, you guys would be able to summarize the indications and evidence for DBT, be able to describe DBT and the biosocial model to a patient, and then also possibly be able to use certain DBT tools in medical practice, including the DBT levels of validation and distress tolerance skills. I'm not sure if anyone else had any questions or kind of interests in mind. If you wanted to type them in the chat or say them out loud, I'd be happy to see if I can fit that in as well. No, so it sounds like your needs are met by my objectives. I'll take that silence as an assumption of that. Oh, actually, now I can see the chat better. Generally curious about my MD JD dual degree, but may not be that relevant. Okay, well, we'll see how much time we have. I'm happy to talk about that as well, if people are interested. All right. So, Evan, I'm not sure, are you able to monitor the chat and kind of let me know?
Yeah, I can monitor the chat as questions come up and read them to you.
Okay.
Someone is asking, curious about pharmacologic approaches. Does it help or hurt this modality?
Okay, yeah, definitely. Can touch on that. Yeah, and feel free to add in if anything else comes up during the talk, or if you have any questions. Happy to answer questions as we go along. So feel free to type in the chat, or you can ask out loud as well. And yeah, thanks, Evan. If you could do that, that'd be great. It's hard for me to see it. All right. So DBT was initially created by Marsha Linehan as a treatment for suicide and self-harm behaviors. So because of this, it's mostly been studied in borderline personality disorder in adults. So its biggest evidence base is for this disorder. So there's been a few different Cochrane reviews of psychotherapies for BPD, and the most recent update in 2020 kind of found that DBT is more effective than treatment as usual at reducing BPD severity, self-harm, and improving psychosocial functioning. So it's mainly used and indicated for BPD, but it has also been studied for some other disorders as well. So just something to be aware of. So there are some RCTs for DBT in the treatment of alcohol and substance use disorders, also binge eating and bulimia, and PTSD. So in this case, the DBT is modified slightly in all of these cases. And then also there's some evidence for DBT as adjunctive to medication management in bipolar disorder and also ADHD. So just to be aware of that as well. So before I kind of describe what DBT is, I kind of wanted to describe a bit about the biosocial theory of how BPD develops from a DBT perspective. But I'm not sure, did Sarah Feinstein kind of use the same model in describing what BPD was, Evan, or did she use?
No, she didn't. It would be worth
Okay.
going through this, yeah.
Okay, yeah, because this is kind of, this is kind of from a DBT viewpoint, how we view how BPD develops. And I think it's really relevant then to kind of understanding the treatment and kind of how it works. So that's why I thought I'd actually start with this. And this is actually something I actually explain to patients. So like if I'm in the emergency department or working elsewhere, I will actually describe this to patients if I do suspect they have BPD. So the biosocial theory is basically that, most things in nature kind of happen on a bit of a spectrum, right? So some people are really tall, some people are really short, most people are somewhere in the middle. And so emotional intensity, kind of emotional reactivity is kind of the same, which makes sense, and kind of studies confirm this. And probably just your general life would confirm this. So you probably have friends, some of whom are more emotionally intense, they get more excited, they get more angry, they're more emotionally intense, and others who are maybe a bit more flat, right? A bit more even keel. And that on its own isn't actually a problem, right? So being emotionally intense is not a problem in itself. You can be emotionally intense and be very functional. And the thought is that most people with BPD are kind of in this upper 10% range in terms of emotional intensity. So most likely people with BPD would be some of those more emotionally intense folks. But again, being emotionally intense is not necessarily a difficulty on its own. What then happens though is sometimes people grow up in an environment where this emotional intensity isn't really understood very well. So, and they're maybe not supported kind of around how to deal with or work with being a more emotionally intense person. And so we call this invalidation in DBT. So validation is like understanding where someone's coming from, kind of expressing, like getting a sense of what makes sense about where they're coming from, whereas invalidation would be the reverse. So kind of really not understanding that emotional intensity. So then what sometimes happens is people experience being told like, calm down, why are you freaking out? Like, stop acting that way, why are you getting so angry? Calm down. So like a lot of invalidation in their environment. So then people will often learn different ways to kind of shift emotions or mask emotions, or even avoid things that are going to bring up strong emotions. So the idea is that actually a lot of the symptoms of BPD, and if you kind of look at the symptom criteria, if you think about like self-harm or suicidal behavior or some of the impulsive behaviors that come with BPD, like substance use or shoplifting or binge eating or etc. A lot of those are actually just ways to shift strong emotions. So they're kind of coping mechanisms that actually might work in the short term in terms of shifting strong emotions, but then sometimes get in the way in the long term. So there are studies to show, right, that actually self-harm does decrease strong emotional arousal. And at the same time, self-harm then sometimes gets in the way in the long run with scarring and different things. And so this is kind of the viewpoint that DBT comes at BPD from, that people are, more emotionally intense, which isn't a difficulty, but then they don't really know how to work with that emotional intensity, experience a lot of invalidation, and end up finding other maladaptive coping mechanisms to work with that emotional intensity. And I do just like to point out, so trauma would be an example of a big form of invalidation, if that makes sense. So not everybody with BPD has a history of trauma, and trauma and BPD are often comorbid. So for some people, it's verbal invalidation. For some people, there can actually be physical abuse and etc. that happens as well. So before I move on from there, any questions about the biosocial theory so far?
There's nothing in the chat right now.
Okay, sounds good. So, and the reason I think it's important to know about this is that actually sharing this with people, they often actually find it quite helpful and quite validating. So when I meet someone in the emergency department who I suspect might have BPD, often the way I'll approach it, there's not much time, right? We can't, I'm not going to be doing a full assessment, that kind of thing. But what I'll often do is actually print out the BPD criteria, just give it to them and see, what do you think of this? Like, does this fit for you? Does this not? For a lot of people, they're like, oh my gosh, this like really describes me. It really resonates with them. And it's really nice for them to kind of have a label and to understand what's going on for them. And if it does fit for them, then I might actually explain to them this biosocial theory and how it makes sense. And I think people often have, it can be really helpful just having that kind of psychoeducation about what BPD is and kind of how it develops. So even if you don't specialize in BPD, you're going to be seeing general patients in family practice or whatever you end up doing later on. If you do suspect someone has BPD, sometimes this can actually be really helpful. Although I know usually actually people avoid giving the diagnosis because of stigma and that kind of thing. Patients actually often find it really helpful. Yeah. So yeah, any other questions?
So there's a question from Christopher. How can you tell in just a hospital visit?
Yeah, so that's the thing, right? I think I wouldn't be making, I think it would be inappropriate probably to make the diagnosis without more of an extensive history, without really going into it with the client. And sometimes you might suspect, right? If they're coming in, they have a history of self-harm, you can see that maybe they might have difficulties with emotion dysregulation, etc. I kind of will just tentatively put it out there and see what they think if the criteria fits for them. So it's less about maybe giving a diagnosis specifically and doing a full assessment and more about raising this as a possibility for them and kind of being open to it, if that makes sense. Because I think you're right. It would be difficult to diagnose someone in just a hospital visit for sure. Yeah, any other questions about the biosocial theory or?
I'm not seeing any. Oh, do you believe that BPD is a lifelong condition or one that can be cured / resolved with treatment?
So I would say definitely the studies show that with DBT treatment for some people, actually they do get full remission of their symptoms. And actually even sometimes in the community without treatment, BPD, they've shown in more longitudinal studies that BPD can't even resolve on its own. So I think there's actually a lot more hope in terms of BPD than was once thought previously in terms of actually improvement and possible remission as well. Yeah, definitely. Awesome question, guys. Anything else?
Just thank you from the person who asked the question.
Thanks, Evan. All right, so the reason I kind of started with that biosocial theory is that actually this really relates then to how DBT works and what DBT is. So DBT is basically like a skills-based psychotherapy. So a lot of it is about learning new skills in order to regulate emotions and kind of work with strong emotions. The B in DBT stands for behavioral. So the idea is that kind of all behavior is caused. It actually makes sense in some way. So if someone's self-harming or they're using substances or whatever's happening, we actually view the self-harm or the substance use as a solution to a problem rather than the problem itself. And so the idea is that by focusing, okay, what is the problem that's leading to the substance use, or what is the problem that's leading to the self-harm, and figuring that out is often the best way to lead to kind of change. And then the D in DBT stands for dialectical. So this piece, it's a bit more complicated to explain. I think the way I find it easiest to understand sometimes is by actually thinking a bit about how Marsha Linehan developed the treatment. So I might give a little bit of a story about that. But so originally she decided, okay, I want to find a treatment for people that have this like chronic suicidal behavior, chronic self-harm. The first thing she did was she went with this behavioral focus, right? So she thought, okay, we're going to focus on, problem solving and kind of changing whatever's leading to the self-harm in the first place. unfortunately, that first kind of trial of things didn't go so well. Just focusing on the behaviors, people tended to get very angry, drop out of treatment quite early. And when she started thinking about it a bit more, she started thinking, you know what, these people have experienced a lot of invalidation through their lives. You know, I think maybe this focus on behavior and changing behavior might actually be quite invalidating to them. So then what she did was she switched the treatment and decided, okay, I'm going to focus on a treatment that's all about validation. So it's going to be about acceptance and like why this behavior actually makes sense, and talking about, you know, validating what makes sense about it. But unfortunately, this approach didn't go so well either. So people again got pretty angry. They ended up dropping out early. And, you know, what they were saying was like, okay, well, this is very nice that you understand me, but like, what am I going to do now? Like, what do I do next? I want to change, you know, I want to stop self-harming. I want to stop using substances. So this is where the dialectic bit came from. She realized that actually what was probably needed in BPD was more of this balance between the dialectic of having both components of acceptance and then components of change within the same treatment. And so what a dialectic is, it's like two things that appear to be opposite that can actually be true at the same time. They form a synthesis. And so the primary dialectic in BPD is this, or sorry, in DBT, is this dialectic between acceptance and change. And so in DBT, we kind of shift from validation to change strategies and back again, depending on how the client or patient is doing in the moment. So if someone's getting very dysregulated, we might shift to more validation. And then when they're kind of on board, we might switch to more pushing for change and kind of problem solving. And this can work really nicely with any patient. So I think it's actually useful to know about and kind of learn about in medicine in general. So an example of a dialectical statement, for example, would be, I'm doing the best I can, and I can do better. So I'm doing the best I can is kind of the acceptance piece. So I'm kind of accepting where I'm at right now. And there's this idea that, and also I can do better. And both are true at the same time. So yeah, any questions about any of that theoretical basis of DBT? I know dialectics and that kind of thing can be a bit confusing.
I'm not seeing anything right now in the chat.
All right, sounds good. All right. So just a bit about the structure of DBT. Are there other clinical, oh wait, I can see that one.
Oh, sorry, there's another question. I can read it out loud though. Are there other clinical contexts beside BPD where DBT is very effective?
I wouldn't say very effective. I would say like there's some evidence. So kind of some of those different conditions I listed at the beginning of the talk, I think those are areas where DBT can be helpful, but there's a lot less evidence than there is for BPD. So like usually more like between 2 to 10 RCTs kind of thing for different disorders. So less evidence than the Cochrane review for BPD. But yes, so like substance use, PTSD, binge eating and bulimia, and then as adjunctive for ADHD and bipolar, I'd say. So DBT generally consists of a year of outpatient treatment. It usually involves 1 hour of individual therapy, 2 hours of group, after hours phone coaching, and then also weekly team meetings for the clinicians to kind of give clinician support. So it's actually a pretty intensive treatment if you think about it. And just so you're kind of aware, I'm not sure if you've ever heard of or seen DBT skills groups in your area where they're just kind of like standalone DBT skills groups. So these have become popular now because they're not as intense, but just to kind of be aware, there isn't as much evidence for just a skills group alone. There is some, there have been some RCTs on these skills groups alone, but when we're talking about the Cochrane review and DBT being effective, that's talking about more this standard comprehensive model. So just to kind of be aware of that when you're referring patients or whatever, that kind of thing. All right, so that's kind of DBT in a nutshell. I was hoping we could actually spend whatever time we have left talking more about some different techniques from DBT that you might find helpful in your clinical practice. But before I move on to that, any other questions anyone has?
Yeah, could you maybe comment on the differences between the DBT and like psychodynamic psychotherapy?
Yeah, so for example, TFP from the previous talk, so transference focused therapy, and then also mentalization-based treatment. Those are both psychodynamically based treatments for BPD. They have also been shown, they have some evidence of efficacy as well. Not as many RCTs as for DBT. MBT probably has the second most evidence, and then TFP the third. I would say one big difference, I would say, is that DBT tends to focus mostly on kind of behaviors and taking a non-judgmental stance to behaviors and just kind of figuring out what's causing the behavior to then shift the behavior. Whereas in psychodynamic and mentalization-based treatments, you would probably be focusing more on some of the psychodynamic processes that are kind of going on for people underlying different interpersonal interactions. The nice thing is, in my opinion, none of the theories of those three therapies actually conflict. They can all work together. They can all be true. They're all true at the same time. So especially mentalization-based treatment and DBT, in a way, can work really well together, like encouraging, and I'm not sure, Evan, if there'll be another talk about MBT, but mentalization-based treatment is really about learning to use theory of mind and kind of mentalize what other people are thinking. And so that can be a great add-on kind of in a way, I'd say, or it doesn't conflict in any way with DBT. I'm not sure if that answers your question or if you had a more specific thought in mind. No? All right. Yeah, any other questions about DBT specifically? Before I shift to, we'll see how many other techniques we can get through. All right. So the first one I wanted to talk about is validation as a technique. So as I mentioned before, this dialectic of validation and change is huge in DBT. But I think validation and knowing how to use it well can be super, super useful in medical practice generally. It might sound simplistic, but it can have like a huge impact. So validation is basically just figuring out what about what this person's saying or how they're reacting makes sense. So kind of finding the grain of truth in whatever's going on. Even if someone's yelling, even if someone's angry, just finding out what makes sense about what's happening. And this is kind of in contrast to things like praise, like so saying good job, or cheerleading, like, oh yeah, like I think you can do this kind of thing, or asking questions, taking a medical history, or like problem solving or offering solutions. So all of those things are useful also, but they're not validation. So just kind of being aware of that. And I think one of the reasons I think validation can be so useful and so important is that actually when people receive validation or they feel validated, it tends to decrease emotional arousal. So if you have a patient that's yelling at you or getting heated, my first go-to would be kind of validation. So kind of figuring out, okay, what makes sense about how this person's acting and how can I validate that? And it tends to kind of bring down the temperature in the room.
So we got one question asking, could you compare / contrast validation with normalization? Phrases like, it's very normal to feel this way in this kind of situation.
Honestly, I think normalization would be a form, well, from a DBT perspective, normalization would be a form of validation. So I would say yeah. So, and well, actually, I'll get to, this is relevant. I'll go to the next slide. So in DBT, we kind of actually identify and break down these 7 different levels of validation. And what I would say normalization would probably be like level 5. So level 5 is like, yeah, that would make sense for anyone. that's very normal. I think a lot of people would feel that way in this situation. So yeah, so DBT actually identifies all these different levels of validation. So level 1, appearing interested, level 2, reflecting, level 3, mind reading. And actually, I'm thinking probably these will be more meaningful if I kind of use a bit of an example. So the next slides kind of cover a bit of that. Like if you imagine a patient comes to you and they're saying, you started me on this medication, now my vision's all messed up and no one's taking me seriously, and they're pissed off, basically. So level 1 of validation is actually appearing interested in what the person is saying. So kind of giving them your full attention. So this might sound obvious. And at the same time, I'm not sure in your context, but where I work, you know, a lot of the note taking is on computer. You can be looking up lab values. You can be doing all sorts of things, right? When you're in a meeting with a patient. And so sometimes actually we aren't fully invested in what the person's saying and fully appearing interested. So especially if you're noticing someone is getting emotionally dysregulated, they're quite upset, actually looking away from the computer, turning away from what you're doing, giving them your full attention can be a really important way to actually validate and show that you're kind of hearing what they're saying. The second level is reflecting. So reflecting is literally just repeating back what the person said to kind of check in that you're hearing them correctly, you're kind of understanding them. I almost think of it as like a verbal way of appearing interested, if that makes sense. So in this case, the person says, you know, you started me on this medication, now my vision's all messed up and no one's taking me seriously. If I respond with like, oh, wow, your vision's off, oh no. You know, I'm not adding any new information. I'm not asking a question. I'm just kind of validating, oh, I'm hearing you, like kind of by repeating back what the person's saying and making sure I'm getting it correct. So again, this might sound simple. And if you try it out with a friend, try it out with patients, you'll be amazed at how much people will then share more. They'll be more engaged in the conversation. They kind of tend to connect more. And also you can make sure you are understanding them correctly, because sometimes they might actually correct you. Like, oh no, that's not what I meant this, right? So it can be quite a useful tool. The third level is mind reading. So this is actually guessing at something that wasn't said. This one can be a bit of a double-edged sword because, you know, if you get it wrong, it tends to not be so validating. But if you do get it right, it tends to be quite validating. And one common way to mind read would be kind of guessing at an emotion that maybe wasn't stated. So if this person's talking about their vision being off, like, oh my gosh, I guess you'd be really worried, hey? Like, you must be so worried, would be an example of mind reading. So they didn't say anything about being worried, and, you know, you might be able to kind of guess that in this situation. All right. And then level 4 is this idea of kind of pointing out, okay, what makes sense about this given the person's past history? So based specifically on this person, kind of what makes sense about what they're saying. So say, for example, in this situation where they're saying, you know, my vision's messed up and no one's taking me seriously. If I say, oh, I know you've told me in the past that medical professionals have missed things, I can see why you're worried I won't take this seriously. You know what I mean? So kind of, okay, this makes sense that this person's getting really worked up about this. I know they've said things have been missed in the past. It makes sense that they'd be worried. And then that's kind of in contrast to what the person who brought up normalizing was kind of talking about, this idea of this would make sense for anyone. It's not just this would make sense based on your history, it's this would make sense for anyone. So like, of course you're worried your vision is off, anyone would be, right? Oh my gosh, you know, of course you're worried. So generally a level 5 is more validating than a level 4. So if you can do a level 5, it makes sense to go for this would make sense for anyone to kind of normalize. The tricky thing is sometimes you can't, right? Sometimes something wouldn't be that way for everyone. So, you know, say for example, you have a friend who's afraid of your chihuahua or something, right? You can't say like, oh, of course you're afraid of my chihuahua. Everyone's afraid of chihuahuas, because that's not the case. But you could say like, oh, you know, I know you've been attacked by dogs in the past. It makes sense to me that you're kind of afraid of my dog. That makes sense. So kind of sometimes you can't normalize. And that's where I think some of the levels below level 5 kind of make sense. So these are the 5 kind of more verbal forms of validation. Does anyone have any questions about any of these before I talk about just the last 2 forms of validation?
I'm not seeing anything in the chat right now.
Okay, sounds good. All right, so the last 2 kind of levels of validation we use in DBT are this idea of radical genuineness and then also functional validation. So radical genuineness is not really like anything specific you would say, but it's just this idea of really connecting with someone on a more human level and trying to remove as much of the power imbalance as you can. So like as a doctor, you can't fully remove the power imbalance, right? So you're a doctor, they're a patient, that will always be the case. And you can still do your best to kind of connect on a human to human level, kind of using language that's not therapizing them, or maybe trying to use less technical language if you can, and just trying to connect with them on a human level. This also involves being like kind of transparent about what you're thinking, like kind of being as open as possible, like within your own limits. Obviously, you don't have to share things you don't want to share, or share things that wouldn't be helpful, but the more you can kind of be open about what you're thinking and what your plan is. And that can be particularly helpful for people who have a history of trauma or have BPD, because they've actually experienced a lot of invalidation usually growing up, or even full-on danger. They often might misread what you're thinking actually. And so the more open you can be and kind of what your thought process is, to just be genuine and open with them, often the easier the interaction will be. And then the last one is functional validation. So to give an example, so sometimes actually validation can be invalidating. And the reason is, so the example I like to give is, if I'm standing on someone's foot, like with my high heel, and they're like, oh my God, you're on my foot with your high heel. If I say like, oh my gosh, that must be so painful, like anyone would be feeling pain in this moment, they're gonna be like, F you, get off my foot, you know what I mean? So sometimes actually what needs to be done is doing something, like functionally, like what's gonna be validating in that moment is to be like, oh my gosh, I'm so sorry, and take your foot off the person's foot, right? And so that's this level of functional validation. So sometimes we can't provide functional validation, and all we have are those other levels of validation. But when we can, functional validation can be validating. So for example, in this case, someone's talking about their vision being off. Okay, well, let me do a physical exam. Let me figure out what's happening with your eye. Is going to be validating and show that you're kind of taking the person seriously. Yeah. So any questions about validation at all?
Just one question about the functional validation. Why wouldn't that be kind of a default response in this particular example?
It could be. So it's a very good point. In theory, if you can go for functional validation, I would say go for it. Possibly just because this is like I went through all the levels, right? So you're right, it's like a bit contrived in a way, right? But in this case, yeah, if you can, totally go for it. Maybe you're not a specialist in this area, you need to send them to see someone else. And then what you're gonna kind of do is like, oh my gosh, it makes sense you're so worried. Okay, let's look into, can I refer you to an ophthalmologist or whatever, that kind of thing. Or who's a good ophthalmologist that you might be able to see. But yes, very good point. Yeah. Any other questions about like this example or the different levels of validation? All right. So I did want to kind of, oops. I did want to kind of have you guys think about this and kind of give it a try. So if you kind of had a patient making this statement, so you're the worst doctor, I'm in pain here, and you're not offering me any treatment. Take a look through these options here and kind of think about which one you think would be the most validating statement. And if people feel comfortable putting their guess in the chat, that would be great. But if not, we can kind of discuss also.
Yeah, please feel free to put your guess in the chat. I will not list your guess with your name, so it's fully anonymous, especially for the recording purposes, if you're worried about being seen, getting something less correct in the recording. So I'm getting a guess for E, B, E, D is functional, someone says.
Great. Okay, so everyone's had
Or
kind of
C,
like
C is functional. They're correcting themselves. And then someone else says C.
all right, so I'm glad this is good. It's like a bit of a space for discussion, which is good. So if I had to choose one, if it was a test, I would probably say B. And the reason I would say B, so B is kind of this level 5 validation. So like, oh my gosh, of course you would be frustrated given the pain you're in and the difficulties accessing treatment. I think anyone would be. I would say, so A, I think A is actually apologizing, which again is not a bad thing, right? It's not a useful strategy. It's just not validation. And it can still be helpful. So I think the I'm sorry part's an apology. The I'm the worst doctor part, I think that would be an example of validating something invalid, likely, unless you are actually the worst doctor, then maybe that you can validate that, but probably not likely if you're the worst doctor. So I'd say that would be like an example of validating something that's invalid. So I wouldn't necessarily say that. C, I would say, would be asking questions, right? So kind of clarifying, okay, so tell me more about the pain, tell me about what kind of treatment you've had so far. Again, can be very useful. And I think what you were saying about it being functional makes sense, right? This is what we would do as a doctor, is find out, okay, more information, I need the history, and then I'm going to make recommendations. So again, similar to apologies, can be very useful. And in DBT, we would actually consider questions and figuring out more about the problem, a change strategy, actually. So more like a problem-solving strategy. And sometimes that can actually be experienced as invalidating, which you wouldn't necessarily expect. But actually, sometimes when you're just wanting to vent about how crappy something is, when someone starts asking questions about it, it can be invalidating sometimes. So it's just something to be aware of, because I think as doctors, that's normal. That's our first response. Okay, tell me more about that. Let me figure out what's going on. And then D, I'm glad you're bringing this up. It sounds important. I would consider that kind of like praise or reinforcement, if that makes sense. So like, yeah, good job on bringing this up. I hope you bring this up again. Like that's going to reinforce them to do it again. And then the last one. So the last one, I would say this could be validation. It could be problem solving. I think I could see, for a lot of these, I can see why you might pick it as validation as well. So E, okay, well, let's try and figure out a plan then. That could be functional validation as well, right? So it's like, okay, you have this problem, we're going to figure it out. And it could be a bit of problem solving. So I'd say like B would probably be the example of like classic validation.
I had someone write in the chat, investigation of the symptoms might be construed as an attempt to discover their falseness.
True, right. So if someone interprets you asking questions as like, oh, they're taking me seriously, that can be validating. But if they interpret it as like, oh, they don't believe me, now they're quizzing me about this, it can be invalidating, actually. So you're right. questions can kind of be a bit tricky that way, for sure. All right. So yeah, so just some kind of tips around validation, making sure not to kind of not validate the invalid. If you are really stuck though, and you can't find anything to validate that seems true, you can always validate the emotion. Like, oh my gosh, it seems like you're really frustrated. That makes sense. Also, it can be useful sometimes to use validation before questions or recommendations. So as physicians, I think we do tend more to like problem solving questions. That's totally natural. It makes sense. That's our job. And, for some patients, I might use like 90% validation and 10% questions and change, which sounds like crazy, but it's like, for some people, for them to not get dysregulated, that's actually what's needed, is like that much validation. So everybody's a bit different, but the idea is kind of this balance of kind of noticing when the person's getting dysregulated. It might be a time to validate rather than asking questions or kind of making recommendations.
Someone wrote in the chat that they liked option E from earlier because it goes underneath the anger and avoids their attempt at a confrontation in the chat.
Yeah, I guess, in a way, sometimes by validating functionally, then you don't actually need to talk about the emotions or kind of validate the emotions underneath. So you can kind of sidestep that a bit. And if they do perceive it kind of as more like avoidance or problem solving, you might need to go back to using some of that verbal validation, like, kind of, oh my gosh, like it makes sense that you're frustrated, you're in a lot of pain. I think that makes a lot of sense, that kind of thing. And then just one last tip about validation. If you use an and rather than a but when you're kind of validating and then suggesting something change, that can be helpful, just because in the English language, I don't know why, but like buts seem to negate what comes before the second part of the sentence. So say, for example, if I say, I can see why you want to go to the hospital, but I don't think it'll be helpful. So the validation part is the first part. So I can see why you want to go to the hospital. That makes sense. But I don't think it'll be helpful. So this is my recommendation. This is my opinion. It's more of the change piece of things. If you replace that with an and, it actually becomes more of a dialectic. So both are true at the same time. So I can see why you want to go to hospital. And I actually personally don't think that'll be helpful. It's very much a nuance. And I would recommend trying it out because it can actually be quite helpful. All right. So any more questions or thoughts or comments about validation? So go ahead.
I was just going to say I'm not seeing anything right now. Sorry.
So we kind of have two options now. So it's 6:50. So we could shift to, oh yes. Oh, I love that question. Validation in the context of hallucinations. So this is one where validating the emotion can be really, really, really important. So say, for example, someone's telling you about like the CIA and they're out to get them and blah, 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 blah. Obviously validating like, of course the CIA is out to get you. That makes perfect sense is not helpful because that's like validating the invalid. And I actually used to use validation a lot with patients with schizophrenia, also with patients who are violent or like angry in the emergency department. It can actually be really helpful. What I usually focus on is just the emotion. So like, oh my gosh, that sounds really scary. That sounds terrifying if you think that people are kind of tracking you or kind of monitoring you. So I won't say people are monitoring you, and yes, that makes sense, but I will kind of validate like, oh geez, that sounds really scary. Let's figure out what we can do about this situation or that kind of thing. Similarly, if people, often if people are, like violent or throwing things in the emergency department or that kind of thing, or on an inpatient unit, I often go with assuming the underlying emotion is actually fear rather than anger, because often there's like a more vulnerable primary emotion under anger. So if you can actually validate, like, you know what, I'm wondering if you're really scared right now. There's a lot of security people standing around. This is a really tense environment. Like sometimes actually just validating that there might be fear underlying it can actually be really helpful to kind of tone things down and calm things down, so that you might be able to de-escalate things without needing like security or medications or that kind of thing. So yeah, this validation, although it sounds simple, it can be a lifesaver in like intense situations often. And my go-to is like, okay, what emotion can I validate often? If that makes sense. So we have a bit of a choice point here. Evan mentioned to leave like 10 minutes for questions. So we can kind of wrap up here and do 10 minutes for questions. The other option is, I did want to I can mention distress tolerance skills, which is another set of skills in DBT that you could possibly find useful in practice going forward. It's a bit more specific, but that could be an option. Do people have a preference between, okay, Chris says skills talk. Anyone else have a strong preference either way?
I was also going to say, since we had questions throughout, we might not need to leave the 10 minutes at the end because people can chime in whenever they have a question. Oh yeah, someone else is reiterating that in the chat too. So I'd love to go with the skills too.
Okay, sounds good. All right, so the second set of techniques I wanted to talk about, so we've done that, are what we refer to in DBT as distress tolerance skills. So the reason I think these might be useful is that these are kind of some of the skills we tend to teach first to people in DBT. They're kind of go-tos, and a lot of patients find them really helpful. So distress tolerance skills are really just skills for getting through a tough situation without making it worse. So they're not about like solving the situation, figuring out what's going on, solving the real problem. They're just about getting through a really tough situation without making it worse. So in a way, they're actually not unlike self-harming or substance use or binge eating or whatever. Those things don't solve the problem either. They're just kind of ways to shift emotions in the short term. The distress tolerance skills are actually kind of similar, but they just have less negative consequences in the long run. And I usually recommend to people kind of using them if their distress is like a 7 out of 10 or higher. So kind of watching for when they're getting that distressed. So there's lots of different distress tolerance skills in DBT. And so I'm hoping to tell you, I might only have time for one set, but I was going to cover 2 of them, but I'll do one at least, I think. So one set of skills is this TIPP skills. So TIPP skills are really like physiology hacks, basically, are the idea behind them. So they're different techniques that help to shift people from a fight or flight response into more of a like rest and digest mode. So like from a sympathetic response to a parasympathetic response. And the way they work is most of them kind of use adaptations that humans have already to kind of achieve this. So the T stands for temperature. And this is actually the way I explain this to patients. So temperature, all mammals kind of have this thing called the dive reflex. And the dive reflex is basically like if you fall into like a lake of cold water and your head gets submerged, like very cold water, I mean, you actually go into a bit of a hibernation mode. So your heart rate slows down, your metabolism slows down, everything actually kind of slows down. And so we can actually harness this to our advantage. If you actually take like 2 ice packs and kind of put them on your temples and hold your breath, or if you dip your face in really cold water, it actually tends to really slow the heart rate down. You can do it like with a monitor and stuff and see it. And this might be why, you know, like when people are frustrated or whatever and they go to the washroom and they kind of splash their face with cold water naturally, like kind of might be people just having an intuitive sense of how this kind of works. But so that's one that can be really helpful for clients when they're looking for something to do rather than self-harming or rather than doing other things. And I kind of explain this to them in that way. I usually give them that idea behind it so they kind of understand the principles and they can kind of use it. Another one is intense exercise. So this one is really, you know, when you're in that fight or flight mode, you are literally primed to run away or fight. And so by doing a bunch of intense exercise briefly, that can actually shift you into more of a parasympathetic state. So in DBT, they recommend like 20 minutes of intense exercise that gets your heart rate up. I honestly teach patients often, if you do, I don't know if you know what burpees are, but they're basically like this exercise where you like jump up in the air and then like jump out into a push-up and then jump up in the air again. If you like look on YouTube for burpees, you'll see it. But if you do 2 minutes of burpees, like you're not going to be upset about anything anymore. You're too tired to be upset. So it can be really effective. Yes, awful exercises, I agree. And very effective for kind of shifting into that parasympathetic drive. And then similarly, so paced breathing, we recommend having people kind of breathe in for 5 seconds, breathe out for 6 seconds. That tends to be around the rhythm that tends to cause that shift into a parasympathetic tone. Usually you'd have to do it for like a minute or 2 for it to happen. And then the last one is paired muscle relaxation. So kind of teaching people to really tense different muscle groups. It doesn't matter which ones, like really tense as tight as they can, and then kind of release them. And again, this tends to kind of, I'd say this is like intense exercise light. So it's kind of like getting out some of that sympathetic energy by tensing and then kind of releasing. So those are kind of the 4 TIPP skills, which we recommend to people. Any questions about any of those? So again, it might feel strange explaining this to a patient. And for patients that suffer with severe anger difficulties or kind of substance use or different things, it can be really helpful, especially if it's emotionally related. All right, it's really down to the wire, but I think I'm going to go for it, if that's okay. I do just want to mention distraction. So that's a second distress tolerance skill, which I think is really helpful. And what I just want to explain is how I explain to people how distraction works. Because, you know, lots of people use distraction, but they don't necessarily think of it as a skill. So the idea is basically like an emotion generally comes and goes as a wave, and it actually lasts like seconds to minutes. But for most people, that's not how they experience emotions. Like most people would say like, no, it can go on for hours, it can go on for days, right? It's not seconds. But what tends to happen is something happens that kind of prompts an emotion. So someone cuts you off in traffic or whatever, anger spikes. And then instead of going down, something else often tends to prompt the emotion to fire again. And we have this saying in DBT, emotions love themselves. So once you're angry, you start thinking about like all the other times you got cut off in traffic and like all sorts of judgments and swear words about the other person. And then that tends to kind of continue. Each time you have a thought that's going to set off more anger, it just keeps kind of going and going. So then the emotion can last hours, days. So the idea behind distraction is actually by turning your mind to something else, to something different, can kind of cut off this emotion from going on and have it actually come down to baseline faster. And so there's lots of different ways to practice distraction. If you just talk to people, they probably are already aware of things that they find distracting, like playing different games on their phone or watching a movie or going for a walk, or, you know, they'll often have things they already know they like, but kind of thinking about it as a skill and thinking about when or how they might use it, I think can be really helpful for people. And then we do have in DBT like a list of different types of distraction techniques or activities, but I don't know if that's really necessary. The idea is just kind of explaining to them how distraction might work can be helpful. All right, so I will stop there. And I know it's time, but I'm also available if anyone has any other questions. I'm kind of happy to stay behind. But otherwise, thanks so much for listening and being interested in learning about DBT. It's really exciting to kind of have medical students early this interested. It's amazing.
Thank you so much for giving that talk. That was a great introduction, I think, for medical students. And thank you everyone also for coming through and learning more about DBT. Of course, I don't know, Anne, if you have some time, if people wanted to ask any questions, but oh, someone's asking if we could have your email address.
Yes, totally. I do have it in the slides, so I can send the slides to Evan to send out if you want. And my contact information is on the last thank you slide, for sure. Yes, I'm happy for anyone to contact me. In terms of pharmacology, I do pharmacology in my clinic for clients. There's no like conflict with doing pharmacological management and DBT. And I did my JD before my MD and changed my mind about being a lawyer. So that's the answer for that one.
There's one question in the chat from a very inquisitive person. What challenges do you face in persuading your patients to use these skills? How do you overcome them?
You know, I would say I tend to kind of step back a fair bit and kind of, you know, if someone's not interested, they're not interested, and that's totally cool with me. It's really more, you know, this is how this works. This is kind of what makes sense to me about it. And, you know, you're welcome to use it if you'd like. If not, that's totally cool. You can notice, I think validation can also be especially useful if you're noticing like a bit of a tug of war. Like if you're feeling like, we call it polarization, but you're feeling like you want the patient to do one thing and they want to do something else, and there's this tension. Sometimes stopping and actually validating their position can be helpful. So like, you know, there's probably something that makes sense about why you don't want to use the skills, you know, and then maybe shifting to a question. What would tell me more about that? Like why do you not think the skills would be helpful, that kind of thing? So yeah, whenever I kind of am feeling that tension between, like I'm trying to persuade someone, I'll usually shift to like actually stepping back and validation. No problem. Thank you to you guys and your interest. It's so amazing.
Someone asks, will you ever encourage a patient to do exercise while in the ER?
You might not believe it, and I have. I have done burpees with a patient in the ER room, like in the interview room, when they've been like so distressed or overwhelmed, they like can't actually participate in the interview, right? They're like just so overwrought or distressed or angry. And you know, this isn't for everyone, and this is up to you, but actually doing it with the patients can be very validating and can also bring down your distress too if you're with a very angry patient. So yeah, self-participation can be helpful too.
I'm going to stop the recording at this point in case it encourages more questions that people might be holding back.